Welcome back to Same Place Worlds Apart. I'm Sabrina.
I'm Callum.
And today we're going to be looking at theme 7, emergency care, preventable mortality and long-term physical health conditions. And today we've got the lovely Joyce Jacca with us. Hi, Joyce.
Hi.
Do you want to introduce yourself and where you come from in terms of your job?
Okay. My name is Joyce Jacca. I live in Deptford. I'm an ex-counsellor, ward counsellor for Evelyn Ward. I'm a generic community development worker, and I work for North Lewisham Primary Care Network. I'm the Health Inequality Community Link worker. I'm probably the first of its kind.
Excellent.
Yeah.
Could you tell us a bit more about that role and why that role came about?
Okay, so during COVID, obviously we were not, the VME, we were not taking COVID vaccinations. Obviously we know that's because they said, take it to Africa. So a lot of us thought, well, let's wait and see what happens, you know. So they did COVID conversations with clinical staff and doctors. And at the same time, they thought, well, let's ask what health inequality is. And when they asked the community what health inequality was, they said, well, we're not happy with the way you do your customer service. When we come to the GPs, sometimes you get the gatekeepers, you're asking for an appointment, and it's kind of like they're trying to deter you from going there. Sometimes people go there and they've got mental health. You know, you're a bit loud if you've got mental health, mental well-being. So they're not treated correctly. People go there and they might have domestic violence. So these are the things. And also they weren't happy that people always consult and never come back and give back and say, well, you know, we consulted to see how many people have got high blood pressure, say, and these are our conclusions and these are the impacts. Nobody comes there. And then they said they wanted someone that could come in the community and come and talk to them and feedback and be a voice for the community. And that's how I kind of came along.
Excellent. So you're well versed to help us get into this theme and unpick it. No pressure. So we're going to go through the report. It's a big report, really, in terms of the theme. So I've got some key notes on here that I want to make sure that we speak on, especially when we talk on the inverse care law, which is something that I didn't know before this report and before being part of the report. So just to say, one of the first sentences in this theme is just to highlight what public health is and what their aim is to do. So public health is the prevention of ill health through promotion of healthier behaviours. So I guess the appointment of someone like yourself is to help feed that through the different primary care networks. Am I correct?
So, well, I work for North Lewisham, so I work in the north. We have 9 GP surgeries. And so in the beginning, what they were saying was that too many people were going to the doctors when they didn't need to.
Okay.
Yeah. And so the idea was to bring in services that people needed, but also to look at health inequality. So in health inequality, it could mean, we've done health checks and we looked at the, I think it's 50-year-olds and that.
Okay.
And we brought them in and it's kind of early intervention. So we gave them a full MOT, so that's blood pressure, BMI and everything. And through that, we were able to detect there were quite a few people that had pre-diabetes or were having diabetes. We could then direct them to where they had to go. So these were some of the measures that we do, because when you do your blood pressure, there's lots of things that you can find out. So we're looking for diabetes, heart disease. We recently also just put in bloods for, like prostate cancer, HIV. Yeah, so it's preventative and early intervention.
Excellent.
Yeah.
Could I
go on.
Could I just jump in and ask?
Yeah.
when you say too many people going to the GP, was it explored why too many people going to the GP?
Well, I don't think they really knew why in the beginning, but even though I work for the NHS, my GP is in that block. So I said it's because sometimes people don't know. For instance, you can go to a pharmacist for some things, but some illnesses are long term. If you think about it, when I was thinking about services, when they're saying too many people were coming there, I was thinking about services that you could bring in so that you could prevent people from going in there. You know, like 80% people go there because they can't sleep or pain management. So if you brought the sleep clinic in once a month and looked at their sleep, if you looked at people's pain management, then they won't need to keep going to the doctors, because that's a waste. You keep going for the same thing. It means that you're not getting anything done. Means you're going there because they're not doing anything about it. You're just coming there. They're either just giving you a pill. But now, where we are now, we've got a wellbeing team. So they do nutrition, they do weight management, they do sleep. And so now those people are being able to be directed there to see how we can manage the pain.
Oh, I love that.
Yeah.
So it's a bit like, so it's, when you're talking about pain management, 'cause I find that really interesting. So when you talk about pain management, it's like how people deal with their pain.
Yeah.
And is that like sort of long-term developing their pain threshold, or is that sort of how they respond to pain? So like, for instance, I know that a lot of the time we'll feel a little bit of something. I just get that ibuprofen. I just get the paracetamol, without even considering why we feel that way. Is that what pain management is? Because I know I'm going a bit off course, but that's interesting.
First of all, I'll say why people do that is because I'm 62, so I can say this. When we were going to work, we couldn't get any time off. So you get a pain, you just carry on with it. Yeah? You just carry on with it. And then eventually, by the time you go, they might say, oh, actually, you're in stage 4, or you're in this, or whatever. You have to manage it. I suppose that comes all from slavery days, when you think about it, how they used to work us. When we were, you were in pain, you still had to go out there and work. Do you know what I mean? But it's supposed to be helping you to manage your pain, and then also looking at your medication that you might have. So you're supposed to, it's supposed to be a holistic approach. Because remember, you're going to a GP, they're just giving you tablets. You ain't getting any further. And then the guy that they had for physio is on the end of a telephone. What, you can see my foot? Can you see my foot on the end of the telephone?
Yeah.
And I know this because I had a bad knee and he did call me.
Oh, wow.
And asking me a question. I said, but can you even see my knee?
So with that, are they giving you exercises to do over the phone? Do they send you something to look at? Or are they just trying to say, oh,
those ones on the one on the phone, everyone complains about the one on the phone. I don't know. I think that's just waste money. But the ones in our place, they will look at you and they might refer you, because we've got physio now. We didn't have that before. We've got physio and we've got someone that does a scan. So sometimes you need a deep scan, not an x-ray. An x-ray doesn't really show much. You need that like deep scan to show whatever, so those people that are doing the pain management, if the pain's too much and they talk to you, whatever, they can refer you to maybe the physio, or send it back to the doctor, say they need to refer to the physio or be referred to the scan so that we can have a deeper look.
So can anyone access those health checks and those preventative supports?
Only the people in North Lewisham. We have 9 GP surgeries. Well, there's 6 PCNs, so everybody should be doing their own thing.
Yeah.
Remember, you wouldn't know this, but we were the pilot. We were the pilot of the health inequalities. And that was all because of COVID. And so we put all those health checks in. and all those measures where other people weren't doing that. So that's how that all came about. And then because we did such a good job and everything, that's now you've got all those hefts in all the other PCN.
Yeah.
And that's why Amina went to public health.
Yes. We
Right.
edited that out.
Oh, okay. Well, that's not bad.
I don't think it
That's-
is.
no,
But
that's not a bad
you said the
thing.
name, just the name.
Yeah, okay.
But could you explain what...
Mm.
So could you explain what a HEF is? Could you said HEF?
Okay, so when we first started off, there was the clinical directors, and then from then there was 3 people that decided about this health and equality thing. So they were 3 doctors in North Lewisham that pushed it and decided they wanted to ask about health and equality.
Okay.
That was Amina,
Sorry. No, carry on. It's fine. It's fine.
Amina, John, and Dr. Fogan.
Okay.
So they were the ones that put the project together and said, we want to do this. We want to look at health and equality. So that's how all of that came about,
Okay.
you know. And then we started looking at, I set up a forum with all the organisations. First of all, I had to look at all the organisations. But because I've worked locally and I live in Deptford, I know all the organisations. So the doctors and that, they didn't know. That's why they brought me in.
Yeah.
So I had to check all of that. Then I started the first forum, which I did with the organisations.
Okay.
And all the way through, everything had to be signed off by the organisations. So we did, because people didn't know what they should be going to the doctors for or where. I suggested that they did this leaflet, and it had QR codes on there, because you know I'm a hand-in-hand person, so I don't like when they say go on Google, go to this link, go to that link. Oh, I've switched off already, right? So I wanted it so that when they look at it, say it's for your teeth, you go in there, you see the picture of the teeth, you see the QR, you go straight into appointments.
Okay.
So we did that first booklet, but that booklet was done with the community, and then we even also consulted with somebody that does work. I think is it Speak Up or something like that? Some organisation that does work with people with disabilities to make sure that anybody could read that thing and it was adaptable to everyone. So that was the thing that we did. So then you could, anything, if you're pregnant, you didn't know where to go, you could just go straight through. And that was one of the first things we did. And we did the forum, which we did every kind of like quarter. And that was to ask, and we asked people, what are your issues? What is health inequality? They said mental health, housing, well-being, environment, and there's another one which has gone out of my head.
Would it be education?
I don't even think education came into it.
Wow.
Yeah, I don't even think they said education.
Okay.
Do you know what I mean? But this was coming from the community of what they
what they felt.
Yeah.
I'm just trying to think, did you actually say what health equity fellow meant?
Did I? Did I not? Okay. All right then. I didn't. Okay, so all right. So when we started, there was a doctor, and then underneath there's a trainee doctor who gets time off to kind of do a project or whatever. But the project that they would be doing is health inequality.
Okay.
So they were called fellows. So we were the pilots. So we were the only ones to have that.
Okay.
But because of the work we did was so good, then that's how, in the end, public health said, "Oh, that works really good." So our boss, Amina, went to public health, and then she was able to roll out so that a HEF is an equity fellow, roller, and all 6 PCNs now have one.
Excellent. So even though they've got each PCN, so primary care network within the borough, has a HEF, a health equity fellow.
Yeah.
Do they do the same support that you can get in North Lewisham? So
No.
Wow.
No.
It's based on area, so the need, is it based on need in the area?
No, I just think we were the pilots, so
Yeah.
we started off what we did, and then people followed. Like, there's supposed to be one of me everywhere,
Okay, I get
but I don't know where the money's gone.
I'm gonna write that
Money
down.
now run. I don't know where the money's gone, but there was supposed to be one of me in everywhere, so everyone should have a community development in there.
Right.
This is the whole idea.
Okay.
Yeah. And then you got the care coordinators, which you have got in everyone now. And people are starting to do the health checks. But out of all the groups, we were doing them fully. We were doing them in the beginning.
Yeah.
No one was doing them, isn't
Yeah.
it? So we do full MOT.
And did you find that what would, and I don't know if you'll know off the top of your head, what were your findings like in terms of like how we engage with stuff like MOTs, and not just how we engage, but like, did you find that like us as a community were people that would go and get an MOT, or was it something that had to be prompted? Because I know a lot of the time we know the doctor thing ain't really something
Well, I
we're
think
into.
I had to go and do a lot of leafleting, and then the other thing is recently what they've been doing is that they can send out messages through the GPs.
Yeah.
Right. This is what they're not doing for the organisations. A lot of the organisations, you'd know that yourself first.
Let me explain that. So there's a health equity fellow in each PCN, and there's also a Black-led organisation attached to each PCN as well, and they are carrying out specific piece of work to do with that PCN. Does that make sense? So these are grassroots organisations. They brought community groups in to support those PCNs.
Cool. Yeah, absolutely.
Yeah, that's what you mean by organisations, right?
Yeah.
Yeah. Okay. Cool.
Yeah.
Cool.
Yeah.
No, it's just I've been like the abbreviations.
I know. I know it's a lot.
You know what it is. In education and social care, I just deal with 50 abbreviations a day. So, and then like you're saying PCN, and it's giving me flashbacks of my penalty charge.
Primary care network.
And I'm like, there's people that are gonna watch and say PCN.
Yeah, there's primary care network.
Primary care network.
Fantastic.
So there's 6, isn't there? So we're North Lewisham.
There's Atlos, which is Sydenham, the Sydenham Forest Hill area. Seven Fields, which is Downham Grove Park. Catford's,
Alliance.
Lewisham Alliance.
It's Lewisham Alliance, which is Hither Green, area.
Lewisham Central.
Yeah.
Modality, which I believe is the Catford South, Catford area.
St John's and
I'll put them in the description. There's a few of them, and then there's an organisation attached to them. So in the description, I'll say who those organisations are.
So we're North Lewisham. So we're from, I don't know if you know the Pepys estate.
Yeah.
Right.
Of course.
Pepys. Pepys estate or Pepys. Samuel Pepys. Right. So from there, and then you go all the way up to even Vesta Road.
Okay.
So the Vesta one, that's ours. Queen's one, that's ours. So Deptford's surgery, Kingfisher, and then in the Waldron we have 3. So Clifton Wright, Amersham, and New Cross.
I never knew those 3 surgeries running through there. Wow. Okay, so you spoke about us not going to GP appointments, and according to statistics, we do appear at A&E. So, but we're appearing at A&E.
Yeah, but we appear, because we don't go to the doctors just like that.
Yeah.
And we can't take time off work. And this is going from way back. You think about it in the slavery days, right? So when we go to A&E, we must be dying. We can't. We've exhausted everything. The rum's not working. The painkillers is not. Because that's how we're going to go to the rum. We do natural, holistic 100%. Approach. And you're going to ring a friend and say, try this. Put 2 ginger, and all these lemon and all of these garlic together, right? And try this. When that don't work. When we go there, then we are really dying. But the other thing is also, when you go to your doctor, sometimes they don't listen. A white person 100%. Will go there, right? And they'll say, my foot hurt me. Okay, I'm going to send you to the consultant. You would have been going, right, till you only have 1 foot, right, in there. Now someone's pushing you in there. And then they'll say, okay, then I'm going to refer you. And you wait, and you're waiting, and you're waiting.
Yeah.
right? And this is the reason.
Yeah.
So you don't have any trust, you don't have any confidence, and sometimes they don't listen.
Yeah.
And they're always quick to try and pile you up with medication. You know, just medication. You know, it's kind of like, yeah, shut up.
Yeah, it's
You
true.
know what
And
I
some of the
mean?
medication,
Yeah.
especially with pain management, is not a joke. Like you got gabapentin, I can't forget the other ones, but
Yeah.
they're really strong drugs.
Yeah.
Well, even down to the really weak ones like ibuprofen.
Yeah.
On a consistent
Yeah.
basis is not good.
Yeah.
For,
No.
It's not very good
Yeah.
for you. But that information isn't massively out there, and I think when you like, I know you've linked it back to sort of our experience with the slave trade, and I want to take it one further and talk about our responsibility to ourselves and how we neglect that at times. So for me, it's like about reframing how we understand health and holistic health. So like, for instance, I'm like in my family and my friendship group, I'm like a herbal man. So when something's wrong, they'll be like, oh, what can I put down here? I put this together with that, with that. But you have to have this for like 2 months at least to start seeing results. There's no point going to get a blood test next week. It's not. It doesn't work that way. But we're used to this instantaneous take a pill and it's fine.
Yeah.
So like, for instance, like I think they say something like, there's this big thing that vitamin D is like one of the biggest deficiencies in the UK. When in actuality, it's a lack of magnesium, because magnesium is what helps you absorb the vitamin D. So it's like that deeper understanding of holistic health and how you have to take it's like long. So when you're talking about CMOS, there's people that are like, oh yeah, I took CMOS for a week and I still feel weak. That's not holistic health. You're talking from a Western perspective. Our perspective is, if you, and this again, and sorry to go on, links back to like sort of some of the findings when we spoke about sort of like the high blood pressure, the diabetes in our community. A lot of us in our community wear diabetes as like a badge of honor. You know what I mean? Or high blood pressure, like it's a badge of honor. I work hard and I eat anything I want and drink anything I want and good genes will carry me. And you get to a certain age and then you get to a certain age and it's like your body is like, I'm not doing this anymore because you've neglected to look after.
Yeah.
And I think for me, it's about reframing what health looks like. And from a holistic perspective, it has to be considered like all the time.
Yeah.
It
But I
can't
think
just be when you're unwell.
Also,
you know?
with that, I can say that sometimes, okay, so I just had a lady in and she's her baby's 3 weeks old. She had gestational diabetes.
Okay.
Now, when she was going to have her checkups, they were so quick to want her to take the metformin.
Oh.
So she took the metformin, but she didn't take them. She did diet-based
Okay.
and just kept doing her check and diet-based. And thankfully, after she had the baby, I think she had blood pressure was still up, so she had about 3 checks, and then they said, "Oh, you're okay now." Okay. And she came in last week, and we were talking about it, and she said, even though they say I'm okay, she said I might go away now and just eat everything, but she would have preferred a lesson on what it might look like if she didn't look after herself.
Yeah.
And I can say that for myself because I have diabetes.
Okay.
And I had gestational diabetes.
Okay.
And as soon as I had my son, that was gone. But nobody ever talked about anything at that time and said anything, oh yeah, you know, eventually you're going to get whatever. But I think to myself, if they would have shown me, or I'd been educated then, because I was 37 then, you would have had the mindset to just eat properly. And some of that we don't get, you know, they don't tell you. Just like, even if we all go to the doctors and some of us stuff that our people have is hereditary. Now, some of us have children, but I was questioning, does it flag up to say that the children should be checked for whatever it is at a certain time? Do you know what I mean? Because even diabetes, you can get that when you're young. My friend's son was 16 when he was diagnosed, had no education or whatever. He's now got on dialysis and everything. He's in his 30s, but didn't realise what he should have been doing. Do you know what I mean? He only started going to diabetes clinic last year. He's on dialysis 3 times a week. He's got glaucoma, you know, in his eye. Now 16. Nothing. So
And a lot of
the education thing is really important. And also the other thing is for us. You know, like, I don't know about your parents because you two are young, but our parents didn't really talk about the lot of health issues that were going on. Yeah. And it's very important for us to let our children know what health issues they are, because you would know when you're pregnant. That's the first thing. Anyone got diabetes? Anyone got, I don't know.
Yeah.
You know, anyone got sickle cell? I don't know. One girl came and she kept drinking a lot of water. And then she goes, Joyce, they said I've got sickle cell. I went home and asked my mum. She said, Mum, them say I have sickle cell. She said, Now, do you see what I mean?
Yeah.
So my parents didn't talk about anything like that. It wasn't until I was pregnant with my first child.
Yeah.
Then asking those questions, and I was like, Mum, have we got this? We've got this. And that's when I started to find out.
No, likewise.
Yeah.
And a lot of the stuff that's hereditary stays dormant.
Yeah.
Can stay dormant until a certain age. And a lot of the stuff that's hereditary, it's hereditary behaviors.
Yeah.
Hereditary genetics.
Yeah.
You know? And we have this thing where we say, black don't crack.
Yeah.
And I keep telling people, black's going to start cracking. It's going to start cracking soon.
I can assure you it does crack.
Look at this, And the reason I say that is because and this is why I go back to genetics.
Yeah.
So, like my grandparents, for example, come from the Caribbean, whatever.
Yeah.
Would walk miles to school.
Yeah.
So, by and large, a lot of the stuff that they may have gone through or may have experienced, as far as ailments are concerned, were offset by the lifestyle they lived.
Yeah.
Fresh food.
Yes.
A lot of exercise. A lot of sunshine. Naturally.
Yes.
Parents were here. Do you know what I mean? As much as it was a lot more like labor, a lot more like walking up and down, fresh food was gone. Walking up and down was gone, and so was the sunshine. Now you got us who are at a desk all the time.
Yeah.
A lot less exercise. A lot less fresh food.
Yeah.
And you start to think to yourself, like, you know, at some point, that genetic makeup that we had that kept us so strong is going to start to be subsided. We have to work out how we integrate that holistic health into our day-to-day living. We can't just keep relying on, well, black don't crack and we're good and whatever, because we're going to it gets to a certain age where it's like,
yeah,
you know?
I've never thought about it like that. I really like that analogy. Yeah, because it's true. We do go by that slogan, don't we? Like, we're going to live forever.
Soon crack, man.
Yeah, we do.
Right, so just looking at the inverse care law. So the inverse care law was suggested 30 years ago by Julian Tudor Hart in a paper for the Lancet to describe a relationship between the need for healthcare and its actual use. Now, for me, what North Lewisham is doing is meeting a demand. So you're looking at the healthcare and the use of it, where I believe that other PCNs within a borough, and I fall under APLOS. By not doing that, this part of the borough, the other side of the borough, are gonna have a lot more health inequalities. Because one thing that I did some research and case studies on the change of how you access the GP surgery now. You can't just go there. You can't queue outside. You've got to call.
Yeah.
Which then means that our seniors have an issue. Or some people that don't have certain phones have an issue. And so I did a few case studies with about 10 seniors. And some of them are diabetic, got all different ailments going on. And they were saying, I haven't had my medication for a month because I can't get a repeat prescription. I can't get to doctor's surgery. Or they're not sending the prescription to the chemist, which is on the back of our surgery. They're sending it to Catford. But this person can't get to Catford. And they're making it the patient's issue and not the surgery's issue.
Yeah, it's the surgery's issues. Because you're saying that they can't get appointments. Some appointments are on the telephone.
Yeah.
What's so good as that? I mean, I can be honest. I always go to the doctors, and this telephone thing I can't do. I'm old school.
Yeah.
I have to see somebody.
Yeah.
But you can imagine those older people. Sometimes they've come and they said, "Oh, your appointment's on the telephone."
Yeah.
What are you going to get from that? Because sometimes you visually need to see people.
Yeah.
But it's not only that. I think one of the things that they should be doing is some of the services that we have it should be cross-borough.
100%.
It should be cross-borough. Because we went and saw, what's the group? The elderly group.
Hummingbird.
Hummingbird. So we went there with a mental health person, myself, a social subscriber, and we also did a food thing in there.
Oh, yes.
And they were so happy and they wanted us to come back. Now, this was last year.
Yeah, I remember.
I've been arguing the case to go back because they asked us there. They were really interested in what we did and the food and wanting to change their lifestyle. Now, my people were saying, oh, well, it's out of the area and whatever. And I goes, do you not know about best model of practice? You need to go there to show that there's a need.
Yeah.
And what you need to understand is our people, they go anywhere where it's good, they'll go, right? So we've got people from North Lewisham in there.
100%. Yep. Yeah.
You see? But you see the mentality. They don't have that understanding of...
Do you think they don't have the understanding?
Well, they don't have the understanding of community development.
Oh, okay, yeah, in that term, yeah, 100%. Because there's no reason
with
why
community development, you go anywhere, you think out the box. Can they read? Can they write? Let's get everyone together. Shared practice, shared methods. Yeah. But you're not keeping everything here. We also, they're target driven, aren't they? But it's all right to have target driven if you're also looking at the solutions.
Yeah, 100%.
And I suppose sometimes what I find is that I don't think that they're looking at solutions as they should.
Yeah.
You know, as they should. So for me, sometimes I just think, I'm there to do health and equality, but how much of that am I doing? Because if I'm bringing back things and you're not looking at it, if I can go out in the community and I come back and I say, there's a football team, there's 82, they're probably about 100 now. I've spoken to the coach and she's telling me about malnutrition. Is that not something big? But you're not doing anything. I've gone to a nursery, Somalian nursery, they've said to me, speech and language, and there's a denial of all those things. But you're not doing anything. Isn't that health inequality? So what is it you want? What is health inequality? Yeah? Because I think if you're doing health inequality, you're supposed to make a difference.
Yeah.
Rather than
make a change. Yeah. You're not going to make it in a day.
No.
Yeah.
But you have to care.
Yeah. Sorry, I'm being very careful of what I say. But just looking at other parts of the report, so it speaks on reducing premature mortality. Now, we had Akila from Maternity Voice Partnerships come in to talk about that and the work that they're doing in terms of supporting parents and mums that are having children. And I feel like from when this report was put together to where they are now, they have progressed. So I know that Akila shared with us that they now have a CQC rating of outstanding in the maternity ward, and that's all with the work of Akila and her team. And I feel like having the Maternity Voice Partnership, I mean, we won't know for now. I mean, we've got to look at these statistics in like 5-10 years, but we're going to see a better progression and a reduction in health inequalities for us. But there needs to be like a MVP, which is Maternity Voice Partnership, for every health inequality.
Yeah, they do, because don't we have in our, that's where everyone comes. We've got guys and Lewisham midwives. We've got the midwife teams in the Waldron. Now that should run hand in hand. I've never heard of that till I saw that interview. That should run hand in hand.
So now it's making me think, what could we do as a community? Because if you're going back saying, actually, this needs to be run over here.
We need to find a way of them being part of, our health. Health inequality thing. Bring them in. Pressure. Because if we've in our health centre, you have to come there if you're going to Guy's and St Thomas or you're going to Lewisham. That's where all the midwives are and you're getting it checked. But I've never heard of these.
Yeah.
They're a very important
They
part.
are. Yeah.
We need them because we probably got people that need to come and see them. And maybe their leaflet should be, there's this book, I think it's called Emily or something, that book. You know that book that they used to give?
Oh, yeah.
Give you?
Oh, my gosh.
There should be a leaflet or page of their thing in that book.
Yeah.
Everybody that's pregnant or they go there they should have that.
Yeah.
They should have that. Their leaflet should be in there. And the other thing is, well, I think while you're talking about this,
Go on.
end of life.
End of life.
End of life.
Right.
End of life.
Before we get to end of life, can we talk about the Vital Five?
Okay, go
So
on.
the Vital Five is to improve the population's health and reduce health inequalities by focusing on the Vital Five to support prevention, detection, health promotion, management and treatment wherever there is an opportunity to do so.
Yeah.
So those 5 things under the Vital Five are blood pressure, obesity, mental health score, alcoholic intake and smoking habits.
Right. So I would say in North Lewisham we've got, is it 4 of those? We've now got a diabetes team. We've got a lead and 2 nurses. And this is all from doing the health checks.
Yeah.
We have lifestyle medicine who do sleep, nutrition, pain management. We have the mental health team, low mental health. I can't get out my bed, you know, that type, and they need the support.
Yeah.
So we have a lead and 2 workers in that one. So I think that we are doing that. And we also have a walk-in and self-referral for mental health, 13 to 25, with a psychiatrist and a doctor, and that is a Monday and a Wednesday. So I think
I didn't know
we are doing that. And I know our diabetes lead person hasn't even been here a year. She's already hit her targets.
Where is this?
The Wardrobe.
North Lewisham, the Wardrobe.
Fantastic. I know.
Sweet one.
Because that's going to be used as a real, like, so that information
Sweet
needs
one.
to be out there as a snippet.
Yeah.
So people can say, actually, those things you just said, that's why I asked you where, because at the end, I want people to say, okay, this is where. So that snippet of information is vital, really, really important. That's fantastic.
Yeah.
Really good.
So we're going to go on to your point in a minute. So just looking at the rapid review that was put together. So the highlights from that were acute diseases and emergency care prevalence. So looking at males with chronic obstructive, I'm going to get this word wrong. You can correct me. Is it pulmonary?
Pulmonary.
Thank you. Disease in Black African and Black Caribbean population are more likely to seek emergency care but less likely to be prescribed medication than white people. Diabetes and poor, again, glycemic control. Dormant. Oh my goodness, I feel like I'm reading Latin. Can someone else read this book? Sorry.
Where are we? Dormant endocrine. I know that because I've had not that, but something.
Okay.
Dominant endocrine disorders for these groups are sickle cell disorders, and these frequently require urgent care for acute events.
Oh, okay.
There are higher rates of asthma in UK-born Black and minority ethnic groups, which is interesting. I didn't know that. I heard that. And there are higher rates of strokes in Black African and Black Caribbean populations due to hypertension, although other risk factors, smoking, coronary heart disease, are less common.
Okay.
Well, I don't think they do enough about sickle cell. Really.
Yeah.
I don't think they do enough. I originally come from Southampton, and we had a sickle cell nurse.
Okay.
And her job was to go to all the events, all the school, test everyone, and then people would add a bracelet.
Okay.
Because, you know, even if you got the trait, if you're going on plane, you might need more oxygen than anybody else. So that was her job for years. Because I can remember from I was like 20. And she's only been retired maybe about 5 years now. So she'd been doing that all that time. That was her job. Every school. and everybody, because I can remember my mum saying, you got to come back to Southampton, get yourself tested from, yeah, you know, so
You're
I
right.
think we don't hear much about sickle cell yet. You would not believe that in the Waldron there is someone in there doing sickle cell.
Oh, wow.
Yeah.
Because I feel like Croydon
yeah,
Borough, they've got that.
yeah.
I can't put the organisation now. I'll put that in the description as well.
So I think that, and then the other thing, well, we were talking about early intervention and everything and all those things. We are really low on the uptake of any cancer screening. Right now, we are high on that. If people are going for their first appointments and not going back for the second appointment.
Yeah.
So the second appointment means that there might be something. It might be something or nothing, because I went my first and had to go back for the second. Do you know what I mean? Thank God, you know, everything was okay. But women are not taking it up, men are not going. So by the time they go, this is why people are ending up in A&E, because with some diseases you've already got to that stage where there's no return. It's just making you comfort and you having to live with it because you didn't go earlier where there could have been that preventative thing. So we're doing, like I was saying this weekend, we're doing a film. There's posters of people that look like us, and that's the other thing as well. You know, when you go to the doctors and you go whatever, and there ain't anyone looking like us, sometimes you can't, you think like, sometimes you think that they might be racist or they might be. Do you know what I mean? Because we do judge people on the first
first couple things that come out their mouth.
On the first few minutes when you go in there and how they speak to you and whether they let you get a word in, right? This is why people don't go back to the doctor. This is why you find people back in A&E, because you'll go in there, right, and people treat you like, you know, you're stupid.
Yeah.
And even like to add to that, like for me, it's not always just about like we'll go in there and find someone's attitude a bit off and presume that they have a racist proclivity or whatever. Like for me, it's more, we know, even if we can't articulate it, the majority of black people know full well that the health system, the justice system, the education system,
it's not for them.
It's not for us. It's to its core, from its inception, largely speaking, wasn't built for us, not to serve us. And we know that, whether we can articulate it or not. Do you see what I'm saying? So I think for us, and I think another thing is like, we need to understand the function of these places.
Time.
So like for us, very
time
much
limit.
So.
Because you know,
so.
like you go in there, they have allocated, sometimes it's 15 minutes.
Yeah.
And you know, the thing is, you go in there, sometimes, you know, your heart's going boom, 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 boom. It takes you maybe about 7 minutes before you fix up yourself to say whatever it is. So by the time you go to say, oh, you're going to have to book another appointment, you haven't got time.
So true.
You know what I mean?
Yeah.
The function of these places isn't to promote holistic health. So education needs to be done potentially, and I don't know if anyone has that, but potentially outside of that framework.
Yeah.
Because we need to be considering what it looks like, not just to get the screening, but what does your health look like? What does your lifestyle look like prior to that? And I take it back to like the pain management and the things we do for pain management. But the offset for some pain management is long-term health implications. Yeah. So we have to be considering at all times, what does my life look like and what do I want my health to look like? It's not to say that you can, you know, you're just like, you know, vegans are just, they're never going to get sick or anything like that. It's not to say anything like that. But it's to say that if you should be conscious of your health from birth, not just like, you know, like, oh,
you're getting older.
I'm 30 now, I'm 40 now. No, from young, we need to be instilling it into children. This, that, and the third. Like, this is what you do when you're sick.
Yeah, we've got ownership.
Yeah.
To do that.
Enough time I see Pitney on the bus with their parent and they got Coca-Cola and they're 4 years old, and I just think, come on, man.
Do you know how many sugars in there?
Oh, they just like
diabetes.
And this is for me. This is the thing for me where when we're talking about education, it needs to be part of it. So like, you'll say, I like this conversation. Why have you given them a Coca-Cola? Oh, they just like Coca-Cola. So for me, in there and then, I know that your thought process isn't even that this drink is full of sugar. That's not your thought process. Your thought process is this is just a nice drink, and that's fine at their age.
Yeah.
You've not considered the implications of it's full of sugar and what that might mean. It's just that it's a nice drink.
Yeah.
So education has to really run deep and be intrinsic on a different level, possibly outside of the health framework in that
It needs
way.
to be, it does. It needs to also start going back to school, because remember, we don't have no nurses, we don't have how many children probably got diabetes that are in the school? We don't know, because you don't check. You're not checking for anything.
Yeah.
So at the end of the day, by the time they do get checked, you know, it's too. You know, so too late. You're going to have to insulin.
Yeah.
Now, but whereas we when we were younger, we were getting regular checks for this and that, you know. And if parents are not talking about what is in the family, you're not aware. It's only when you get older and you're going to the doctor and they say, "Oh, you got this. You must have it in your family because it's hereditary." And you're thinking, "No, well, my mum never said anything." Do you know what I mean?
Yeah.
So I think it's time, but it's time for change. It's time for us to be telling people, and maybe more promotional stuff.
Yeah.
Out.
Yeah. Right, so before we get on to your bit, just emergency care access, and I'm going to read this. People from ethnic minority groups are 25% more likely to be a casualty than white pedestrians in trauma road accidents. I didn't know that until obviously going through the report. Violent crime through the uneven reporting suggest high rates of gun and knife crime in areas of deprivation, often including young black males. There is a increased risk of admissions observed for patients of black African and black or black British ethnicity linked to poor management of chronic diseases.
Do you know what I don't like? I don't like when they say about only crime is only where there's deprivation. I really don't like that, and they need to stop saying that. Oh, it's Deptford, you know, this area is really, you know, underprivileged, you know. So what? It might look like we don't have no clothes, the way they talk about you, you know. And I constantly say, why do you talk about us like that?
Yeah.
You know,
it's because of, I can't remember the index now. There's a certain index that shows the deprivation, and Deptford has got one of the highest indications. Where again, looking at where I'm from in the borough, our deprivation rate is a bit lower, but it doesn't mean that the deprivation is not there. But then what then happens is when funding comes available, the north of the borough will get the money because your deprivation is higher. But I've always said my concern by doing that and not having it for the whole borough is that areas like where I'm from are going to be the new deprivation in 10 years.
Yeah, but if we're getting that money, are we seeing that money, or is it only just going on target things? Is it making a difference? I don't think there's any point. I don't think there's any point in giving money in the area, right? And you don't see no change.
Yeah, absolutely.
I really don't. And then half of it is still spent in house. Do you understand what I'm saying? Ooh. So we can't see so we're going to be forever deprived area. Because we're deprived anyway. Yeah.
I think it's so funny. Like, it's getting into like politics a bit, but I just think anyone who has worked in enough places, I'm past being able to be convinced that poverty isn't by design. I almost, as much as I know 1 + 1 is 2, is as much as I'm certain that poverty is by design and maintained by design. And I think when we there's certain language in some reports that will make people disengage. Because we're like I said before, you may not have people may not have the language to articulate it sometimes, you know, but they're like, come on, man, we know what we know, and we don't know what we don't know, but we know what we know, whether we can say, do you know what I mean?
So going on to preventable mortality and obviously death. One thing that I was with you, wasn't I, when we did that course at the Waldron, and they spoke about life expectancies in different parts of the borough, and it was really sad to see like Deptford. I can't remember what the total was, but the age. But then looking at Blackheath, it's totally different. And I wanted to also highlight about the asthma, and hopefully you can help me out with the young girl that passed away in Deptford. And their mum's been petitioning, done a really amazing job at highlighting the air pollution within our borough.
Yeah.
Oh,
I think, yeah.
yeah.
Yeah, that was in Deptford Park School.
Yeah.
And I know with that in the it's the Evelyn ward. We did a lot of they did a lot of research and did a lot of testing. Even in the houses, there were certain things that they did to try and learn more about it.
Yeah.
But I don't know. There is a lot of pollution around there because the amount of cars that used to come down there. I know they've got the cycling thing now, and I don't even know if that's the amount of accidents that have happened there. I don't know if it's whatever, but generally around there is a lot of everywhere. There's a lot of air pollution, and if you've got asthma, I'm an asthma sufferer myself. You see, when it gets to like the winter,
that cold air,
the car fumes.
Ooh.
I can't take the car fumes. So by the time I've left my house, I've got on the bus and I get to work, I'm literally in the toilet just being sick.
Oh, wow.
I didn't realise what it was until earlier this year, and they said what it is it's your asthma. It's the car fumes that's making me sick. So I don't know what they can do about that. Asthma, they don't. Quite a lot of children are getting that, but it's not diagnosed till later on. But it takes one to know one. You know, one person, if someone else has got those breathing difficulties or whatever, you know that that they've got those. But then I think for those children that are at that school, they used to be out there in the playground, didn't they? And it's near the road, so you're going to get all those. You imagine you're playing out there all the time. And so maybe it's for them to be looking at what else can they do, because they're so near the road.
Because
that girl was so near that. That girl. So because the school is near the main road, isn't it? So that's why you're playing in there. The wall backs off. So you're just getting all of that.
Of course.
So maybe they should have been thinking about, well, should the children really be playing round that side? Maybe they should be round the other side. Do you know what I mean?
But it's also those that live in that area as well. So obviously we've got the schools there, but if you live on that street,
if you live on that street,
ridiculous. So you wanted to talk on the preventable mortality bit.
End of life.
Sorry.
I just think that we've had, even through working with the group that we work with, HIV.
Okay, you can name them.
Okay, Red Ribbon, HIV. Because one of their things is they go in the hospitals and support those people. And it's been like shocking for some of them.
Really?
Left in your own,
Are these HIV patients?
Yeah, really? That are on the way. Obviously, the end of life. Won't clean them. They've had to clean them. Won't touch them. Won't whatever. But
is that because of the stigma around HIV and not understanding how to look after someone with HIV?
Well, you're a nurse.
People think that
you're a nurse.
But some people are so ignorant.
You're a nurse. You should have that training, shouldn't you?
Yeah.
But it's not only that. I think also us. I would say the black community and that we have a certain way of dealing with our people when they are doing end of life. You'll get 50 people around the whatever. But now it's like they don't want people to be going around, only one people can go around, and I just think sometimes they're taking away some of our cultural thing, and I don't think they should be allowed to. The same as, we're talking about that, the pregnancy thing after you've had the baby now. We used to be at home for at least 10 days. Day 5, you got to go to the clinic. They only come out once. You got to go to the clinic. So you've had 50-degree stitches. You still got to go to. So are they removing our cultural?
Of course.
Yeah, they are.
Our cultural stuff. And to me, I think that's really sad, and we shouldn't allow that. We shouldn't allow that. We have certain things that we know we have to do for our people if it's end of life. and they should be going with dignity.
Yes.
Yeah,
Mm-hmm.
people have worked here all their life. They paid their taxes. Why are they not treated like human beings?
Yeah.
Mm-hmm. Mm-hmm.
You know.
Yeah.
So I want to highlight that because obviously, as we say, we've got a lot of people going A&E,
Yeah.
and sometimes people, when they've gone, it's too late.
Yeah.
They find out stage 4 cancer and whatever. And these are the things that we need to put in place. Who's going to go? Do we have people that can go around and see them? Can they allow us to give that person a fair healthcare,
Yeah.
isn't it?
Yeah, exactly.
They've been
Yeah.
paying for their healthcare. They've
Yeah.
been paying NHS,
Mm-hmm.
national insurance and all that.
Yeah.
So why can they not go with dignity? And is it not time that those nurses and everyone, they're trained, so they know.
Mm-hmm.
Yeah. Let's just not just talk about HIV. It might be cancer. It might be something else.
Yeah.
Yeah. It's important that we have these things in place, because if we're talking about health inequality, that's an inequality.
Yeah. And I feel like during COVID as well, when all of us lost somebody at least.
Yeah, and you
That
couldn't
was,
go.
yeah, you
Oh
couldn't
my
even go
God.
inside. And
Yeah,
you
we
couldn't-
had that. I couldn't
or
see
one
my
person
nephew.
at a time.
Yeah, well, I couldn't see my nephew.
Yeah.
Yeah.
That was, I think that was so hard for a lot of us that knew that our loved one was going to pass away, but you couldn't even go to the hospital to say bye.
And I think, and I've got to be cautious how I word this. It's there's a particular level of rebellion which has always maintained civility in the world. It's never been the conformer who has maintained peace in the world, ever. That's never been, it's never been, oh, we go along with it and we'll work through the process and then that will change things.
Yeah.
That has never been the case. So to some degree, there has to be a level of, no, this is what we do. This is our culture. Like it or lump it. Do you see what I'm saying?
That's when they call security.
Yeah, they're going to have to call security. Yeah. And that's why all 50 of us have to rock up there and go see grandma.
Only
Grandma,
five,
I mean,
only 2 people in the room. Only 2. What?
Nah,
If your grandma?
Yeah.
Granny's on end of life.
You're mad.
Everybody's supposed to go
Everyone's there, even the neighbours.
Because she'd be
Everyone's there.
expecting everyone to
Yeah.
turn up.
And this starts.
And bringing our food as well.
And this starts from earlier. Like this, like all it, like things we need. And I didn't realize I was so passionate about this topic. You know, I thought I was going to be quite quiet on this one, but like I'm really passionate about it because like when we're talking about prevention, even down to like we were talking about pregnancy, to be doing the tests at pregnancy, it might be a little bit too late.
Yeah.
You should have done that. We should know these things. When we're talking about 50 people turning up to go see Granny, but none of us ain't chipped in to go see Granny in 20 years.
Yeah.
These things need to be really pushed and instilled from early. And I'm really like, this is my message just to the community that you like habits have to be built from really early, and you got to really push yourself to do those habits because it will benefit you as well. Like when I'm old, I want my Grand Pitney them come check me
they
and
should
bring
be
my
looking
soup
after
and
you. You look after them and you show them those words of wisdom, and they will in turn come and look after you.
Yeah.
Yeah,
You
exactly.
know, because they'll know, oh my God, I better go and do his locks because he likes his locks certain way.
They should have
You know
put
what
it
I mean? No, because I know.
Yeah.
Do you know, like, I can remember when my mum died, because my mum died early, 52, whatever, my gran was still there. But my mum never said, well, when I die, because my gran is in Kenya, and my mum never said, you have to send money or you have to go and see her regularly. I used to see my mum do that, so I just
So he's
did it.
done it. You'd have to be told.
So this is why what you're saying is important. If you see that, then you just do it. Just like if you see when you're younger and you watch your mum cooking jerk chicken or whatever, you take that in and then one day you think, yeah, Charlie, I'm going to make jerk chicken. I'll be watching mum.
Yeah.
You know what I mean?
Yeah.
And then you do it. So these things are instilled with you, you know? So, I think it's important.
Absolutely.
To do that.
That's a really good example.
Right, so just going on to the long-term conditions. So what they found was there's higher rates Why is this always doing this to me? Every time it's my time to read. Hey, Callum.
You can't read.
I know that are my glasses, you know. What
I'm dyslexic.
What one are we looking at? What one are we looking at?
It's so full.
We found higher rates of multimorbidity, polypharmacy, and earlier onset. Increased prevalence of diabetes mellitus. Is that right?
I don't even know what metallicis is.
Okay,
What it is.
Find out.
They
Put it in
should,
the
you know what?
something
This
for us to
language
look
thing
at.
is really also.
It's
this
not
is
friendly.
It's not friendly.
It's not.
Because, you know, like, because I do community development.
Yeah.
You have to think, can they read? Can they see? You have to think out of the box.
Yeah.
Do we need the loop in here because some people are deaf?
Yes.
I don't even know what that word is.
Yeah.
What is it?
Well, to their credit, actually, there is a index at the bottom.
Look how tiny that is.
So but what I'm saying is
So you can find out what it
it
is.
references where you can
at the
go to
bottom.
find out about
Yeah,
it.
but why did they have to do that in the first place? You could have a reference at the back, right? Just if it's shut the door, if that's camera, let me know it's camera.
Yeah.
I don't want to know it's, you know. And that's how we are. That's how our people are.
Yeah.
Do you know what I mean?
Yeah.
Straightforward. That's the problem.
Earlier onset of cardiovascular and chronic kidney diseases. They found higher risk and earlier onset of some cancers. For example, the risk of being diagnosed with prostate cancer is approximately 1 in 4 for black men and 1 in 8 for white men within the UK. Lower rates of COPD and multiple sclerosis. Inequitable change in healthcare.
Yeah. Because some people don't know. It's education. Some people don't even know the signs. Yeah.
Yeah.
Some people prostate cancer, right? Maybe they've had blood in their urine, or they've been messing up their pants or whatever, and just didn't take it as anything. Do you know what I mean? Some of it is education. Need that education out early, and it needs to be people like us talking to people like us.
Yeah.
Yeah, don't bother with anything because nobody wants to listen to anyone.
Yeah.
Even those elderly people, we listen to the elderly people. So we need to go to more places. So if you're going to a place where it's over 50, you go there and we talk, right, you're over 50, this is what you've got to look out for.
Yeah.
You need regular,
Yeah.
you know, but if you instill all this in from they're younger, which is
young.
your point, yeah, so we should be going into the schools
Yeah.
and maybe, I don't know, year 10 are trained to tell the younger ones. You do like a trainer,
Yeah.
and so they train the younger ones, and when they gone, those younger ones train the so people know. Because also you need to have a place where you can discuss all these things.
Yeah. Yeah.
It's
know?
all linked.
Yeah, it's all.
And I know there's like people that will watch this and say, how much do you want the schools to do?
Yeah.
And my argument is always, well, you need a whole reform of the education system. They're learning a lot of stuff that isn't relevant. They're with you for 8 hours a day.
Yeah.
They're with you more than they're with me during the week. During their formative years, during the week, they're with you more than they're with me. So who's going to raise them? You've set up the system like this. You have to have a hand in raising them.
Yeah.
It's not to say you have to instill the principles that we would instill from our culture, but you have to have a hand in teaching them about their health.
Well, we've got the highest teenage pregnancy. We've got the highest sexual diseases in teenagers and whatever. Yes, we have in Lewisham.
So schools have a hand, yeah.
So the schools have a thing.
They
Tell
do.
them.
Yeah.
Yeah.
They do. They have a duty.
They have to tell them. Yes. Do you know what I mean? It's not because you're, if you're 13, you can't get pregnant.
Yeah.
If you're 12 or you're 14, you can't get sexual disease because you're too young. No, you can't get everything.
Everything.
Yeah. Right? So they need to educate them.
Yeah.
Because I don't believe that they educate them properly. And they are going out there and doing it.
Yeah.
You know?
Yeah.
Children are getting younger and younger now. So it's up to the parents also to educate. I'm not saying that you should say, yeah, you can't go and do blah, 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 blah.
Yeah.
Let's put on the program where she's giving birth.
Yeah.
You soon know about this. You do that, this is what's going to happen.
Exactly.
You know, like, you have to tell them properly, you know what I mean?
You have to tell them
After that,
raw,
you're
man.
so scared, right? You're not even, You know what I mean?
They wanna
If
touch
I
their
put
one.
their hand on you, you know, do you know what I mean? But I think, you know, it's education.
Yeah.
Absolutely.
Right, we're gonna tie it down now. The opportunities for action for this is very, very long. So just going through the key findings again. So Black African, Black Caribbean are more likely to seek emergency care, higher rates of asthma in our community, and higher levels of stroke. And like what Callum said, 1 in 4 Black men will be diagnosed with prostate cancer, and 1 in 9 white men will be diagnosed with prostate cancer. And one thing I just wanted to say, that Prostate Cancer UK are doing a lot of work in supporting the community. So we have the Walking Men group, and they've been down there and done a really good talk to get the men to understand what prostate cancer is, understanding that you don't have to do that, the thing that all men think you got to do to get tested for. Because obviously
you can do blood.
Because our men ain't letting nobody do that. So understanding and demystifying some of the things that we thought was what it is. So I have to just big up them for the efforts that they're making.
Absolutely.
But these opportunities for action, I don't even know how to read them. Have you seen? Have a look at them. Look,
They're long, and I'll attempt to
because
reduce
we've got
them.
about 5 minutes left.
So the first one is about ensuring culturally appropriate data is collected and analysed for service planning.
Right, so that means that we're very good at collecting data, but we just lump everyone in the same bracket. So if you're Black, you're all Jamaican, African. And it needs to be more defined. So if you're Nigerian, it should state that you're Nigerian and whatever, because who knows? More Nigerian people might have higher blood pressure than a Caribbean person, but we'd never know because we're clumped all together.
We're all one thing.
Well, I'm usually quite critical of the actions for change, of the opportunities for action, but these are quite detailed. I can't go through them all because they're each one is, these are the longest ones I've seen.
Yeah.
And they're really detailed. So it does, in that one, speak about it being supported by clear commissioning that requires data collection. There should be better scrutiny of data.
Yes.
And so it does go into some of those things, which is good. The second one is ensuring that engagement of Black African and Black Caribbean communities is meaningful and valid. And then again, it's got a good few bullet points, and it speaks about sort of how the use of faith in workplaces, team community advocates and grassroots organisations.
Where the money there. That's okay. As long as you got funding and all that to run alongside it, and also you've got exit strategies. So once you start, you've got funding and the people start. As soon as they start, you've got to be looking for the next lot of money, because what happens is they start things for us, and then afterwards it's gone.
Yeah.
And you can see that it's a good impact, but there's no money along it.
Yeah.
And they're always doing that to us.
Politics
now,
and tick boxing.
But we need to try and make sure that this is not so.
Yeah. And so the point you made about having the advocates and using faith groups, I think that's so important.
Absolutely.
And if we had all churches and all faith establishments,
that's community development principles.
I think that'd be amazing. Just having a wall just dedicated to helping the place, and we can get help.
Part of the things they say is we're hard to reach. We're not hard to reach. It's because you're not going where we are. As a community development worker, I go into the community.
Yeah, you're everywhere.
I will go. Yeah. So I'm going in the mosque.
Yep.
I'm going in that hut.
Yeah.
I'm going to that Domino's meeting all the old guys there and telling them about prostate cancer.
Yeah.
That's what we do, and that's what they need to do. Stop. We sent 10 letters and no one's come to us.
Yeah, it doesn't work like that. We congregate in mass every Sunday.
Yeah.
Do you see what I'm saying? Don't say we congregate in mass.
You know where to find us
every Sunday. So stop.
Yeah.
And what's the last one?
The last one is ensuring prevention services are fair, appropriate, and consider the needs of Black African and Black Caribbean populations. It speaks about services considering evidence-based ethnic differences. Talks about outcomes for different communities, working with communities to encourage and raise awareness about how to access health services.
Yeah, we're doing that, but on the
preventative.
Yes. I don't know what's happening. No, it must be the water. I was going to say that it should be a fair thing that everybody has it,
Do you know
Because
what?
one thing I think with the NHS, they a lot of the time, right, it's because it's target driven. It'd be different targeted group where it needs to be equality.
Yeah.
So
Equity.
everybody gets a chance.
Yeah.
There's one here
Yes.
that I think might.
Yeah. Okay.
And I'm usually quite critical.
okay.
It's,
Where's
it's funny that today it's taken a whole different thing. Like, this is the most detailed they've done, that opportunities for action. So I commend them on these three,
Okay.
unlike the others.
Yeah.
Right.
So this one says early help provision that supports communities
Yes.
when they do not meet statutory thresholds, such as improved investment in grassroots organisations to provide social prescribed and support.
Yeah.
So I think that alludes to a little bit what you was talking about.
Yeah.
Like it needs not like this tick boxing blanket thing. Like you need to be able to reach everybody.
Yeah, you need to reach everyone.
And be mindful in how
So
you
you
do
go
that.
where they are. You go to the nursery. You go everywhere. You go to the mothers and babies club because you know they're going to be there. Ask them a question. Test them. Yeah. You want to do health checks. Test them there.
Yeah.
You know, and that's how you're going to get everyone, because otherwise you're just doing the odd two. Oh yeah, 20 people. They've probably only seen 20 people. Oh yeah, 80% people are blah blah blah. What? Where did you go?
Yeah.
Because you didn't reach where we are. Because I'm damn sure if you, in all the communities, if you wrote and you said, oh, how many of you have heard from your health profession? How many of you, and everybody would say the same thing. No, I haven't. Do you know what I mean? So although we are doing things, but it needs to be better.
Yeah.
There's room for improvement.
100%. Yeah. Well, we've come to the end of our segment. Thank you so much, Joyce. How do you feel?
Well, I would have been better if I had a drink.
Our guests are just full of banter. You're not getting invited back.
Good. I really enjoyed myself. Yeah, easy talking.
Excellent.
Yeah.
All right, guys, thank you for tuning in, and we'll see you next time.
Like, share, what's that one? Subscribe,
Comment.
Negotiate, meet
And
people
also
in the
that bell.
comments.
That bell thing. Get your notification on so you know when we're releasing new videos as well. See you later.